General Manager. Please join me in welcoming the General Manager.
Well, thank you, and Bernie, and good morning, everybody. I don't think I've ever been introduced as a profound speaker before, so that's a lot of pressure. I know there's always a certain amount of discomfort associated with inviting a medic to be a speaker at a breakfast or a lunch, because you never quite know what they're going to talk about. There's always that concern of maybe they'll talk about something that's unpleasant or lay a guilt trip on us for our lifestyle choices. I promise I will do none of those things. So this is a great opportunity to share with you what we're doing as the source of medical support for the Air Force and for the Joint Team. Just as the demands for capabilities from our Air Force are rapidly evolving and changing and growing, that then generates new requirements for us in terms of providing medical support to the Air Force. And so I'll kind of walk you through, use some vignettes to describe how that's evolving, and then what we're doing in order to be prepared to support the airmen and the Joint Team as they go about their mission into the future. I'll start by describing something that happened about 3 weeks ago as an illustration of how things have changed in terms of requirements for medical support. And this occurred in a location in North Africa. And as you know, we have forces engaged in counterterrorism operations across North Africa. And we do that as part of a coalition. And so there was a French soldier in a location in North Africa who was part of a counterterrorism operation, incurred 2 gunshot wounds to the chest. He was taken by his French colleagues to a local hospital, and as the local hospital was not well prepared to handle trauma, and as they were evaluating the French soldier, the commander of the French soldier concluded that this was not the right place for the soldier to be. Now the French commander knew that the nearest French military field hospital was more than 2 hours away. And so the commander decided to remove the soldier and transport the soldier to a U.S. military capability that was closer. And so that brought the soldier to a U.S. Air Force surgical team. They evaluated the soldier and determined that he needed immediate surgery in order to save him. He was going into shock. And so that team operated on the soldier. They did intra-abdominal surgery to stop the hemorrhage. They removed some partial removal of organs that had to be removed, and they stabilized the soldier, administered blood products in the forms of transfusions and other blood products, and then they provided critical care support to that French soldier until such time as he could be aeromedically evacuated to Europe. And so that sounds like a somewhat familiar scenario and story, but I'll tell you that what's different about that story is that the U.S. Air Force surgical team that operated on that soldier was not located in a hospital. They had set up a makeshift operating room in a building of opportunity. They were not located in a field hospital, so it was a single small surgical team with a small critical care staff that stabilized the patient. And so, and they were located a full 4 hours from the nearest hospital capability of any kind for the U.S. or the coalition forces. And so they maintained blood products, had those ready to administer, which is the standard of care for trauma medicine now. They administered anesthesia, they operated, they stabilized, they held the patient, provided critical care support, and then aeromedical evacuation moved the patient. So the first hospital that soldier saw was actually in Western Europe, up in France, where he was taken by aerovac. And so that's a quite different scenario from what we were used to seeing in Iraq and Afghanistan. And that has really required that we evolve our capabilities to be able to have surgical teams that can move with the operation, set up in locations of opportunity, and provide that kind of life-saving stabilization. And so we have mobile surgical teams, the U.S. Air Force does in North Africa now, that actually move and relocate as the operations occur. And so you might ask, well, why don't we just put a field hospital there? And really the answer is that we have a relatively small force covering a huge expanse of geography. The counterterrorism operations in North Africa actually cover an expanse that is the size of the continental United States. And so that's why, as that operation has evolved, we've had to evolve our capability to where we can have a small surgical capability and critical care team that can actually move with the operation and locate where they know the operation is going to be. And so they have supported a number of coalition casualties as they have done this, and so that's a great example. The other thing that's different about that scenario is that the aeromedical evacuation team that moved our patients from that kind of operation, they are now moving patients who have yet to see their first hospital. And so that has led us to some new requirements in terms of developing and advancing our capability to actually do stabilization while we are flying and moving a patient. Whereas in Iraq and Afghanistan, they would be stabilized and then moved to Germany. We now have a requirement to pick up patients that perhaps have not seen a hospital yet and actually continue the stabilization operations and provide more care and intervention as we fly them. And so we are actively engaged in the process of evolving the way we organize, train, and equip our medical teams to do that. So in terms of our deployable medical support for the Air Force, we have a field hospital we call an expeditionary medical system, EMEDS as we call it. Then we have aeromedical evacuation capability, and with the aeromedical evacuation we have critical care transport teams. And so that enables us to move patients, usually within 24 hours after they've been wounded, to a location where they will be in a medical center that meets Western standards. And that capability to stabilize and move quickly has actually made a big difference in terms of good outcomes for the wounded forces in Iraq and Afghanistan. That said, we know that we need to continue to advance that capability to be able to do more intervention, more diagnostic work, and more therapeutic work in the air. And so we have active research that's continuously in progress to develop our capability there. The thing that has proven helpful about an Air Force field hospital is it is small, it can move without a lot of airlift requirement, and it is flexible, it's modular. And so the surgical team I just described to you in North Africa, that is one of the modules of an EMEDS. And because we have built it both in terms of equipment and personnel packages so that we can separate modules and deploy modules independently, that's given us the flexibility that's proved very useful in terms of being able to adapt. And so in the North Africa scenario, and supporting counterterrorism ops, we've actually taken the surgical module out of the EMEDS, married it up with the critical care module with AeroVac, and we put those teams together on the ground, and that's proven to be the right combination of medical capability to support that mission. We continue to work to modernize the equipment sets in our deployable hospitals. We do that out of a central logistics operation in San Antonio on what used to be Kelly Air Force Base, Fort San Antonio they now call it. And our medical logistics specialists build the equipment sets. We have organizations that continue to test and adapt the equipment that's in the deployable hospital. As technology has evolved in U.S. medicine, that has presented opportunities to take new equipment that we use in the critical care units in U.S. hospitals and adapt it to the field environment. New technology has become smaller with the advent of microprocessors. Essentially, all medical equipment now has a microprocessor in there somewhere. That has made equipment more durable, smaller, lightweight, even compatible with the flight environment in many cases. And so we have an organization that continually upgrades and improves the capability in anesthesia equipment, critical care equipment, and adapts that to the EMEDs. And then through central logistics, we're able to keep all of the equipment sets matched up and ready to go. The flexibility of the EMEDs proved valuable during the Ebola response last year when it was recognized that the healthcare workers in Liberia treating Ebola patients needed a good hospital on the ground in order to be treated if they themselves contracted the virus. And so as the State Department looked at how they could help Liberia with this capability, they determined that the EMEDs was probably the most flexible, deployable field hospital to take in. And so the team from Langley Air Force Medical Group there went to Monrovia. This was before the Ebola outbreak was really under control at all. So went into a country where Ebola was very much spreading rapidly through the populace. And they prepared a site. They determined how to reconfigure an EMEDs to treat an infectious disease. Our logistics specialists changed the supply in there to match the requirement for treating an infectious disease. They set that up. Then the U.S. Public Health Service came into Monrovia, staffed that hospital, and it did treat a number of Ebola patients and actually had a very good record in terms of survival rates among the patients they treated in that hospital. Other countries who are allies to the U.S. have gained the equipment set and use it. So today the Ukrainian military is using an EMEDS equipment set that the U.S. Air Force went in and taught them how to use it, how to operate it, and train their medical forces on how to utilize it. So that's where we fit into the Joint Team in Air Force Medicine. Is we have a lightweight modular capability that can come in with minimal airlift and get a surgical stabilization and a small hospital capacity on the ground operating within hours. When the situation requires a large hospital, then the Army and Navy come in with a much bigger capacity. It takes much longer for that to move into place. Of course, the Navy has the ships, the Comfort and the Mercy. Those capabilities all take a great deal of time and logistics to move. Our contribution to the Joint Team is to be able to get there quickly, stabilize, and prepare people to be evacuated as the case may require. As we have gained experience over the last 15, almost 16 years of war, our medical capabilities that we apply in the deployed environment have changed considerably. When I came in the Air Force, the doctrine was that we would never deploy or use a neurosurgeon or a vascular surgeon or a subspecialist like that in a field hospital. We didn't think there was anything they could do in their skill set in a field setting. But today they are actually integral and a key part of what we do. And that's because the advent of technology and new techniques and equipment have enabled them to actually apply special techniques that actually help save limbs from amputation and save lives. And so I'll give you an example in vascular surgery. One of our senior vascular surgeons in the Air Force now, Colonel Todd Rasmussen, as a young vascular surgeon in the U.S. Air Force working on a Wilford Hall Medical Center in San Antonio, they installed a state-of-the-art vascular medicine suite in Wilford Hall that was able to actually designed to intervene in patients with cardiovascular disease by working from the inside of the arteries with no incision, working with catheters and things, and to treat things like aortic aneurysms and things that are associated with cardiovascular disease. Todd and his teammates saw a potential in some of those techniques to actually treat trauma victims, and that had never been tried. And so they started doing research at Wilford Hall, and they actually developed a technique where they were pretty sure that they could stop major hemorrhage within the abdomen and chest just by putting a catheter quickly up through an artery in the leg. And so the question is how did they take this multi-million-dollar vascular suite in a U.S. medical center and take that into a field environment? And so Todd and his team determined that you could do this kind of work with much more basic, even analog equipment. And they developed the technique, did the research to demonstrate it, and actually that technique is used today in Bagram in Afghanistan, but also was initially used in Balad in Iraq, and a number of instances in which our surgeons are now able to stop hemorrhage quickly in a patient that would have been previously thought unsalvageable due to injury to a major vessel inside the abdomen or chest. And so that kind of capability has saved lives, and so that is now a standard part of our deployable armamentarium as medics. That then presents us with the challenge of keeping those kind of teams ready and giving them the kind of medical practice day to day that will keep their skills current, just as you would keep a fighter pilot or any other military specialist current in their skill set. And so that's really changed the way we keep our deployable teams ready. We know that the Air Force population we serve in our hospitals and clinics tend to be relatively young and healthy bunch of people. And so a lot of times they don't really present for the kind of care that a vascular surgeon needs to stay ready. And so we've really gone to an open model of keeping our teams ready now. And by that I mean we leverage partnerships. And so our Air Force hospitals, where we have specialists who are on deployable teams, we have partnerships with VA hospitals who will refer patients to them. That's good for the VA patients because it gives them good access to specialists. It's good for our people because it gives them a more complex care in their practice. We also have partnerships with local trauma centers. And so through training affiliation agreements, our trauma specialists will rotate through the local trauma centers and take trauma call in the community. So the example I'll give you is at Nellis Air Force Base in Las Vegas. Our vascular surgeons there, they do cases at the hospital on base at Nellis that are referred from the VA. They will also go do more complex cases at the VA hospital. And then they take trauma call at the University Medical Center in downtown Las Vegas, which is the level 1 trauma center for Las Vegas. And so through that kind of open medical practice, these surgeons are absolutely current in all of the skill sets we need in a vascular surgeon, and they do deploy, and when they deploy, they go with complete currency in all of their skills. We are doing that kind of model, leveraging partnerships, both in the federal sector, but also in the private sector, in all of the locations where we have hospitals that deploy our surgical and trauma teams and our critical care teams. And as we do that, we've developed clinical currency standards that we call full spectrum readiness. Just as the line of the Air Force talks about full spectrum readiness for all of our military capabilities, we have full spectrum readiness standards for our medical capabilities. And so our commanders of our hospitals, they manage to those standards now. And we are now working with the Army and Navy to do that in a consistent way so that we actually present and measure the readiness of our forces based on those full spectrum readiness standards. It's a new concept, but we're working closely together with the Army and Navy to do that in a common way. So we have in the Air Force 75 hospitals and clinics around the world. Most of them are clinics. The Air Force mission is such that many of our installations are relatively small and they don't really have a population that would support a hospital. But we do have 8 hospitals around the world that are what we call our deployment platforms. And that's where we have our EMEDS personnel and our critical care personnel embedded. All of our hospitals and clinics exist for several reasons. First and foremost, it's to support the mission. And the Air Force mission is such that we have commanders who are actually conducting operations from our installations at most places, even within the continental United States, whether it's global mobility, remotely piloted aircraft operations, intel fusion centers, cyber ops, nuclear deterrence, ground-based nuclear deterrence. All of these are conducted from our installations in the U.S. as well as around the world. And so our medical groups are supporting those commanders who are conducting those operations. So we have an important role in ensuring the readiness of the airmen who are conducting those missions. And the demand on those airmen has really grown, especially in the vigilance part of the Air Force mission, the part that involves the intel control stations, the RPA operations, the maintenance career fields are significantly stressed now, and we have significant shortfalls, which has led our chief and secretary to ask for a growth in end strength. But medical commanders are integral to helping commanders support those airmen. And so our hospitals and clinics have a key role there. Out of those hospitals and clinics, we also support families, of course. And we believe that is very important to our ability to support commanders taking care of families under stress. And families of active duty members today, they're in an economy that's stressful. They are serving in a mission that imposes stress. And so by providing their medical care and support, whether it's primary care medicine, specialty medicine, family advocacy, we are able to best help that commander support active duty families under support. So our chief and secretary have been committed to continue to provide good support to active duty families through our hospitals and clinics. Of course, out of those hospitals and clinics, we keep the medical team ready, and then out of the hospitals in particular, we do the kind of research I described at Wilford Hall, where they develop the vascular surgery techniques. We continue to do operationally relevant medical research out of our hospitals. And so the vascular surgery technique I described to you a minute ago that Todd Rasmussen developed, where you put the balloon up into the aorta to stop hemorrhage, that led to the development of a trauma-specific intravascular balloon, which is now patented and is now, the license has been purchased, and it's used in trauma centers all around the world. Developed, by an Air Force vascular surgeon to meet a wartime need. And so today, research continues on those kind of vascular techniques at David Grant Medical Center in California, where we have a young vascular surgeon there, a major, who's leading a research project, and he's working on a technique to be able to use that kind of treatment even before the wounded member reaches a hospital. He's working on a technique to be able to put a balloon like that in and stop major hemorrhage out in the field before transport by helicopter to a hospital. Amazing stuff, but it's what the hospitals enable. And so this deployable capability that we have really comes about because of the military health system. And so I wanted to make a few comments for you about our military health system. And that, of course, consists of Army, Navy, and Air Force medicine. The Navy, of course, supporting the Marine Corps as well. And the Defense Health Agency. I think the information I'd like to share with you is that the military health system is really more tightly federated than it has ever been historically. In the last 3 years, since 2013, Army, Navy, Air Force, and worked together with the Department of Defense. We created the Defense Health Agency. We did that in order to achieve savings and to create 10 shared services, as we call them. That has saved hundreds of millions of dollars in the defense budget already, and the savings continues to accrue year to year. We overhauled our governance system so that we could work together in a tighter alliance. In 2014, we did a complete top-to-bottom review of the military health system together, and we called in three of the nation's elite health systems to help us do that: Kaiser Permanente, Geisinger, and Intermountain Health. Out of that review, we developed an action plan, and we agreed to tighten our collaboration. And so there were 85 action items that came out of that review, and we are well into considerable progress on all 85 of those action items. Part of what came out of those action items was a consolidated process of managing our performance as a health system and to measure our performance against national benchmarks. So I can tell you for the Air Force, we have new dashboards, we have new performance measures against national benchmarks. And we are seeing that we are outperforming the national benchmarks in a number of areas now. Perinatal medicine, our surgical outcomes are exceeding the national benchmarks. We're expanding the number of hospitals that are measuring performance against the surgical benchmarks. Our care for diabetics against national benchmark, we're now moved up beyond the 85th percentile and tracking up towards the 90th percentile. We have a number of benchmarks like this, and so as we manage our performance year to year, we are identifying areas where we want to focus our improvement efforts to make sure that the health care we provide to the people we serve, which is a very special population, is every bit as good as they could get in any of the elite healthcare systems in the country. And we are doing that in a very tight collaboration with the Army and the Navy. We are in the process in DoD of acquiring a new electronic health record, and we worked very closely together on that acquisition process, which is managed out of the Department of Defense. But the services all work together to build the requirements, and I think that acquisition has gone very well, and we are now approximately 7 months from the initial operating capability of the new electronic health record, with the initial sites being up in the Pacific Northwest. Fairchild Air Force Base will be the first Air Force installation to use the new record. That new record will give us a data capability that will really directly help us understand the health risk of our patients and help our patients mitigate their risk and live a long, healthy life. And so we think the advent of that new record is very important. It will take us about 5 years to get it entirely deployed. It just takes that long for a system this large to do that. But it's going to bring a lot of new capabilities that will be very beneficial to our patients. Among those will be a new patient portal, so the ability for the patient to manage their appointments, to manage their prescriptions, access their health record, be able to share parts of their health record. If they go to an emergency room, they will be able to, through a health information exchange, make their record available to the people treating them. And so in a number of ways, this will be very helpful. It will also allow our patients the opportunity to interact with us for health education, health coaching, and so we believe this will be a great benefit to those we serve. Our collaboration also includes a joint trauma system. And through our experience in Iraq and Afghanistan, we have captured the data from every wounded soldier, sailor, airman, and Marine that we have treated. That has been maintained in a registry, a database. We call it the Joint Trauma Registry. That has proven to be a very, very helpful mechanism for identifying ways to adjust treatment to improve outcomes. And so out of the Military Health Systems Joint Trauma Registry has come research that has been published in peer-reviewed journals around the world and has actually made significant changes in the way trauma patients are managed in hospitals all over the world. Examples are the fluid resuscitation for burn patients. Totally different now based on what we learned in Iraq and used with new guidelines in the civilian sector as well that came from our data. The use of blood products to resuscitate trauma patients and how we manage fluid resuscitation trauma has changed dramatically based on what we learned in Iraq and Afghanistan. So that is benefiting trauma patients all over the U.S. and all over the world. So significant collateral benefits to people everywhere from what we've learned by working together as a military health system. So in conclusion, I think the main point I would share with you is that the military health system is really a tight collaboration, and particularly over the 3 years, we have collaborated to a much greater extent than we have historically, and I think that is really benefiting us in terms of the joint deployable capability, but also in terms of our performance as a health system. We've generated a lot of savings. We're closing seams. We're coordinating our performance management as a health system, and we have a lot of solid evidence of progress. And today we continue to work together in order to make sure that we're capable and ready to meet the challenges of the mission going forward. We are working now to align our deployable capabilities. The counterterrorism support scenario I described to you at the beginning has highlighted the need to have more interoperability between Army, Navy, and Air Force mobile surgical teams. So we have a work in progress in order to become more interchangeable in that capability. And then we are also now jointly managing our research to meet the future operational requirements. I know that nationally there is concern about the budget, and the budgetary pressures are significant. And currently, the health support to the DoD beneficiary population is roughly 7% of the DoD budget. And there is concern that as medical inflation has ramped up a bit nationally, that will grow towards 10% of the DoD budget. So we understand that concern, and we know that's very important. I think, and so that's generated a lot of discussions about how can we reduce the cost of the medical support to the DoD mission and to the DoD beneficiary population. And so I think over the coming year you're gonna see a lot of discussion of that as Congress considers the National Defense Authorization Act. I think going forward, as we consider how we can reduce the cost, I think there are certain elements of what we do that are very important for our future capability to support the mission and those who serve in the mission. One is, I think it's very important that the military hospitals and clinics function within a command structure. We are a force provider. The deployable capability I've described to you requires that we keep those medical airmen ready, and that's really commander's business. And so we think it is quite important that we continue to function in a command structure, and we also think linkage to the operational mission we support is very important. And that's why in the Air Force we've always seen our medical groups work for a wing commander. As the Surgeon General, I am not a commander in the Air Force. I'm a staff officer, and that's exactly how it should be. Our medical group commanders are aligned to the commanders of the mission they support, and that has worked well for our mission, and we believe that linkage is absolutely important to keeping our capability aligned to what the mission needs. The scope of our capabilities is important. Sometimes you may look at what we do in a military hospital and clinic, and you would say, well, why do you need to do pediatrics or obstetrics? But actually, all of that knits together in terms of our support to families, but also enhances our deployable capability. If you look at our experience in Iraq and Afghanistan, a lot of the patients we treated were local population in many cases who got caught up in warfare, and so treated children, treated women. A lot of the work we do with capacity building on behalf, in partnership with the combatant commanders in the State Department, involves pediatric care, public health measures to prevent neonatal death, to help children survive things like infantile diarrhea or malaria. And so the full scope of care we provide actually gives the combatant commanders and the U.S. that medical capability to use to help build relationships. Another important aspect going forward are the partnerships I described with the private sector and other health systems in the federal sector. Those are key to our readiness. I think it helps us in regard to our relationship with the VA, provide good access to specialty care for veterans. It helps us in terms of maintaining our readiness and our partnerships with trauma centers and academic institutions. They value those partnerships because they gain the experience of our people who have significant deployed trauma experience. And we value it because it gives us access to trauma patients who need complex care and support. And so as the budgetary pressures are considered, I think the important thing to remember is that 60% of the cost for health support to DoD is actually in purchased care. What we call the direct care system, our hospitals and clinics constitutes 40% of the cost of health support in DoD. And so, but with that portion we call the direct care system, you get more than just care. We actually get a deployable capability. We get operational support to the airmen who are serving in the mission. We get support to commanders who are helping families under stress. And so there is a lot that is gained from that 40% of the health budget for DoD. And so we know this is going to be an active dialogue in the coming year because of the concern about cost. And as we engage in that, we will be focused on making the adjustments we need to make to keep the cost in the right window as set by our leadership and by our Congress, while at the same time doing our best to ensure we have all the deployable capability we need to provide the good outcomes for those that go in harm's way. And so I appreciate your time this morning, and Bernie, is there time for questions?
Sir, thank you very much for those insightful comments. General Ediger has agreed kindly to answer whatever questions you might have this morning as time allows. I'd ask that as you have a question, raise your hand and we'll bring a microphone to you, and we'd ask that you identify yourself by name and organization. So are there any questions for General Ediger?
Morning, General. I'm Philip Source with the Air Force Times. I was curious if you could go into a little more detail about the training and equipment for the mobile surgical teams that might be different than what you find in the field hospital.
One piece of the training for the personnel is the linkage to the operational mission. We develop new training so that they are able to identify a suitable site to set up a surgical location, but also so that they are prepared to be able to move and relocate with the operational force as required. This is a capability that we've had in special operations for several years, but now that the requirement has grown, we've now moved what normally was a special operations capability, and we've blended more of that into our conventional mobile surgical team. So out of our EMEDS training at Camp Bullis in San Antonio, but then also at the School of Aerospace Medicine in Dayton, Ohio, we are in the process of putting together what we call an Osteo surgical team training course that will actually package together the things so that the members of the mobile surgical team are trained to work with the critical care transport team that we're coupling them up with. They're trained in terms of how to work in a more tactical environment. It still needs to be suitably secure, but how they can move it in a more tactical way where they are really located in places that sometimes are, quote, outside the wire, so they need to know how to do that safely. And in terms of equipment sets, we continue to evolve the capability in all aspects of that. We use equipment sets that are standardized and consistent with what will be seen when they move into a med center, so that if it's an orthopedic trauma case, the fixator equipment matches what will be seen when they get to a U.S. medical center. We modernize the anesthesia equipment. The ability to store and maintain blood products in a challenging environment is a significant focus for our research. There's very active research in DoD to be able to develop blood products that don't require refrigeration, that can be reconstituted in the field, and a lot of research in that area. So that's just an overview of some of the things.
General, I'm Brigadier General Pata from South Africa. I've got some few questions. I know you know our structure of how our medical system is working, but I want to ask you about how many people can the field hospital take at district hospital, and Navy, Marine, all of them, they have that's that kind of hospital. And then, sorry to answer that's too many questions. How do you keep the specialists in the medical system? Are you not getting competition in the private sector by recruiting some of them?
Okay. In terms of the capacity of our field hospitals, as I said, our Air Force field hospitals, the Linkage is relatively small. It can come in really four different capacities, three different. We have one version where it can go out without any hospital beds at all. It will go out with just an operating room, an emergency room, and a dental clinic. We call that the HRT, Humanitarian Response Package. That's the smallest version. We can then add a 10-bed hospital capacity to that, 10 beds, or then we can go up to 25 beds, and that's as big as we get. The Army and the Navy have much larger field hospitals that they can deploy and put into place. But our role is to come in with the lightweight, rapidly available capability. In terms of keeping specialists in the hospital, that's something that requires continuing management and attention. I've got Brigadier General Jay Burks back sitting at the table behind you, who actually leads our team that does exactly that. And we get most of our physicians and other kinds of medical specialists in the Air Force through scholarships. And through the scholarships, they're able to graduate from medical school debt-free, but in return they owe time to the Air Force, and the Army and Navy do the same thing. We also have the medical school at the Bethesda, the Uniformed Services University, by which we get very fine physicians. We continually work to try to keep our specialists beyond the time of their commitment. And we are in competition with the private sector very much. We use some special pay authorities Congress gives us to help retain them. But I'll tell you, a big part of what helps us with retaining, particularly our trauma specialists, are these partnerships that I talked about. Our trauma specialists value being in the Air Force because they are able to practice in our partner institutions and take trauma call, conduct research on operationally relevant things like I described with the vascular surgeons. And so that's a unique type of practice, and then the ability to deploy and apply their skills in support of the mission. Our trauma specialists value that, and that's a big part of retaining them. The type of deployed experience they get, but also the kind of experience they get in our partner institutions. So those partnerships, we think, are key to sustaining a good trauma and critical care force. Great example of that is Baltimore Shock Trauma, probably one of the premier trauma hospitals in the world. They've got 3 trauma teams at Baltimore Shock Trauma. One of those 3 teams has a significant Air Force presence on it. We assign Air Force trauma and critical care specialists to that hospital. They work there every day, day to day. And then by virtue of having them there, we are able to rotate trauma and critical care people through there to refresh their skills before they deploy. And so that's been key to retaining specialists.
Hi, General. Neil Richmond, EMC. Regarding the readiness of the medical corps, what's your evaluation in the ability of the Air Force to use things like data and data analytics to help you with these decisions?
I think right now, I would describe our data management analytic capability as good, but not great. I think we are limited right now by the electronic health record we have, which is probably a first-generation electronic health record, ALTA as we call it. And so I think as we move into the new electronic health record, we will have the latest generation of electronic health record, which will give us much better access to data. We do have good data analytics teams, and we do have some data warehousing capability that we are leveraging. But we are significantly challenged on the interoperability side. Because we have a first-generation electronic health record, it really wasn't built or designed to share data with other systems. That's a common scenario in the U.S. right now. The new electronic health record is built to the national standards using what they call an HL7 data interface. And that's the new standard that is being employed nationally for health systems to be able to exchange data. So what that'll mean for the patient is as they present for care in a different system from perhaps the one they're enrolled to, their data will be able to move back and forth between systems and keep their health record digitally intact. We have some degree of interoperability now with the VA, but because both we and the VA have first-generation records right now, that interoperability is kind of through some bridging applications. But when we and the VA both have our new electronic health records, they will be built to the same standard, so our data will exchange much more freely and readily. As you get a new electronic health record, you have to have a data management strategy too. And so we do have an effort underway to build our data management strategy. So good but not great right now, but on a solid path to have a robust interoperability and data management strategy capability.
Morning, General. Thanks very much for speaking with us today. It was very interesting. My name is Marina Malenik. I'm with Jane's Defense Weekly. And I just have two questions for you. First, a quick follow-up on the field hospitals. I think you had said during the course of your talk that they don't require a lot of airlift capability. Can you just describe how they get around and in what types of aircraft? And my second question is on your new combat rescue helicopter. What kinds of new capabilities in the medical field are you expecting to come out of that?
In terms of the airlift support for a field hospital, our smallest configuration, one we call the humanitarian response team, the HRT, that can move in a single C-17 with both the personnel and the pallets for the equipment. Our field hospitals do require a certain amount of support on the ground for security, transportation, water supply, those kind of things. They do come with their own power generation and their own, heating or air conditioning capability, but they do require some support on the ground. And then as we expand all the way up to the EMEDS 25 capability, then we're in the range where it would require two C-17s to move the package. They can move with a C-130 as well. It just takes more C-130s than it would C-17s, obviously, because of difference in capability. They can move that way as well. And then I forgot your second question. Oh, the combat rescue helicopter. And so in combat rescue, the medical capability we use in the personnel recovery mission are actually in the pararescuemen. And pararescuemen are war fighters, as we know, but we train them and certify them as paramedics. And so as they built the requirements for the new combat rescue helicopter, they have fully incorporated the requirements that the pararescuemen would need in order to practice as paramedics in the helicopter. And so obviously with that helicopter is an important retrieval capability, but then also the ability, once if there's an injured party on board, access to the electrical power, oxygen supplies, and those kind of things to enable the pararescuemen to actually treat a patient.
Thank you.
General Ediger, thank you very much. We take an informal tally during the presentations about the quality of the presentation and how close to profound it gets. And we do this through social media online. And for some speakers, they get a little lapel pin, others get a challenge coin. For you, sir, we have a profound Air Force Association medallion. Thank you very much. That was very insightful, sir. Thank you.